Imagine you are standing right there in the trauma bay. A high-velocity motorcycle crash just rolled through the doors.
Right, a classic high-stress scenario.
Exactly. The patient's right arm is completely flaccid, just hanging off the gurney. You do a rapid assessment, and in the next 60 seconds, well, without a single MRI, without any advanced imaging at all, you need to know exactly which microscopic nerve root in their cervical spine has been physically avulsed from the spinal cord.
Which is terrifying if you don't know your anatomy cold.
It really is. So, you test the rhomboids, dead. You test their serratus anterior, dead. Because you understand the wiring, you immediately know this is a catastrophic preganglionic root avulsion. Today, in this deep dive, we are going to teach you how to see that invisible wiring.
Yeah, we are going to build a functional nerve map of the upper limb. If you are preparing for the FRCS trauma and orthopedics exam, you already have the catalog of origins and insertion.
Right, we are definitely not doing rote memorization today.
No, absolutely not. The examiners are testing your applied knowledge as a surgeon. For almost every structure we discuss, they want to know two things. First, which specific cord or nerve supplies it? And second, which anatomical bottleneck, that danger space, that nerve must travel through.
Because that's where it is vulnerable to trauma or, your scalpel. We are mapping the highways and the intersections.
Exactly.
The nerve cell highways and the tight fascial compartments, the bony notches, the surgical intervals, those are the dangerous intersections. Understand those, and you basically understand the anatomy of surgical complications.
I like that analogy. To trace those neural highways properly, we have to start at the mechanical foundation they serve. The primary joint of the upper extremity.
The shoulder.
Right, the shoulder. It relies almost entirely on its soft tissue envelope because it actively trades bony stability for a massive arc of mobility. You are balancing a really large humeral head on a very shallow glenoid socket.
Like a golf ball on a tee.
Exactly like that. Which means the dynamic stabilizers are just constantly firing.
So we're talking about the rotator cuff. We have the supraspinatus, the infraspinatus, the teres minor, and the subscapularis forming that continuous musculotendinous hood.
Yes, the core four.
But let's jump straight into the biomechanics of the supraspinatus because there is this persistent myth taught in medical schools that the examiners actively use to trap candidates.
Oh, the 15-degree rule?
Yeah, that classic teaching that supraspinatus only initiates abduction, like it handles the first 15 degrees to get the arm moving, and then the deltoid takes over the heavy lifting while the supraspinatus just relaxes.
So that 15-degree rule is fundamentally wrong, and it is a guaranteed failed question if you rely on it. The supraspinatus is active throughout the entire arc of abduction.
It never turns off.
Never. From 0 to 180 degrees, it is firing continuously. I will state that again because it goes against all that outdated dogma. The supraspinatus is active throughout the entire arc of abduction.
Let's actually break down the force vectors to explain why it has to fire the whole time. Think about the origin and insertion of the deltoid.
Okay, let's do that.
It originates on the acromion and inserts laterally on the deltoid tuberosity. When your arm is resting at your side, at 0 degrees, the line of pull for the deltoid is almost perfectly vertical.
Straight up and down.
Right. So if the deltoid fires in isolation, without the rotator cuff, it isn't going to abduct the arm. It is going to pull the humeral head straight up, translating it superiorly and slamming it directly into the underside of the coracoacromial arch.
Yeah, you would get massive superior migration and impingement. The supraspinatus, originating medially in the supraspinous fossa, has a horizontal line of pull.
So it pulls inwards.
Exactly. Its primary job during abduction is not to lift the arm, but to act as a dynamic compressor. It pulls the humeral head medially, actively compressing it into the concavity of the glenoid.
By locking the head into the socket, the supraspinatus provides a fixed, stable fulcrum.
And once that fulcrum is established, the deltoid's vertical force vector is converted into rotary motion, allowing the arm to abduct safely. And because the deltoid wants to pull the head superiorly during the entire movement, the supraspinatus must continue compressing the joint through the entire range of motion.
That makes perfect mechanical sense. So the supraspinatus works throughout all of abduction, but that muscular hood we just described is not, a perfect, impenetrable sphere.
No, it has a gap.
There is a structural weakness, a gap in the armor, And the examiners want to know exactly where the rotator cuff is anatomically deficient.
The strict anatomical answer is that the rotator cuff is deficient inferiorly. At the very bottom of the capsule, let me lock that in for you right now. The rotator cuff is physically deficient inferiorly.
I know candidates often get caught here, right? They really want to answer anterior.
Well, all the time.
Because they visualize a trauma patient in the emergency department with a classic anterior shoulder dislocation with the humeral head sitting in front of the glenoid. So they logically deduce that if the head escapes out the front, the hole must be in the front.
I mean, it is a reasonable clinical deduction, but it's anatomically incorrect. The subscapularis muscle provides a massive thick barrier across the anterior aspect of the joint.
You can't just push through that.
Right. The actual tendinous deficiency is inferior. When a patient suffers a traumatic dislocation, the head initially subluxates inferiorly through that weak capsule before the muscular pull of the pectoralis and the subscapularis yanks it anteriorly to rest under the coracoid.
So the mechanism of injury puts it in the front eventually, but the actual structural hole in the rotator cuff is trickly inferior.
Exactly. Deficient inferiorly.
So if the dynamic stabilizers have a gap, we have to rely on the static restraints, the glenohumeral ligaments. We really need to talk about the primary restraint to anterior translation.
Absolutely. The thickest and most critical static restraint is the inferior glenohumeral ligament complex. You can think of it acting like a fascial hammock strung under the humeral head.
And it has 3 parts, right?
Yes, it consists of an anterior band, a posterior band, and an axillary pouch in between them.
But it doesn't do much when your arm is just resting at your side. The tension on that ligament depends entirely on the spatial orientation of the arm. The exam question will ask for the specific limb position that isolates and tests the inferior glenohumeral ligament.
That ligament becomes the primary restraint to anterior translation only when the arm is placed in abduction and external rotation.
The throwing position.
Yes, the late cocking phase of throwing a baseball. When you elevate the arm and externally rotate it, that anterior band of the inferior glenohumeral ligament wraps tightly across the front of the joint, physically blocking the humeral head from sliding out anteriorly.
And if you apply a violent anterior force to the joint while it is locked in that abducted, externally rotated position, say a rugby tackle pulling the arm backward, that ligament fails.
It fails right at its attachment point on the glenoid. That violent avulsion of the inferior glenohumeral ligament from the anteroinferior glenoid rim is the classic Bankart lesion.
That's a huge exam point.
Huge. I will repeat the definition because it is the absolute cornerstone of shoulder instability. A Bankart lesion is the avulsion of the inferior glenohumeral ligament from the anteroinferior glenoid. You must repair that labor ligamentous complex to restore the hammock and stop the recurrent anterior dislocations.
Got it. Now, before we move on to the wiring, let's quickly touch on the subacromial bursa. In a clinical setting, we inject local anesthetic and steroids into this space all the time for impingement syndrome.
Yeah, very common procedure.
The bursa is sitting right on top of the supraspinatus tendon, cushioning it from the acromion above.
The exam focuses on the physical barrier between that bursa and the main glenohumeral joint space beneath it. In a normal, intact shoulder, the subacromial bursa does not communicate with the glenohumeral joint.
They are totally separate.
Completely. The intact supraspinatus tendon forms a watertight seal separating the two compartments. I will emphasize this. A normal bursa does not communicate with the joint.
But if an orthopedic radiologist injects contrast dye directly into the glenohumeral joint for an arthrogram, and the dye immediately leaks upward, filling the subacromial bursa, well, you have your diagnosis.
The watertight seal is broken. The dye leaking from the joint into the bursa indicates a full-thickness rotator cuff tear. The tendon has ruptured all the way through, creating a direct physical channel between the two spaces.
Let's distill this shoulder foundation before we get into the nerves. If you only keep one concept from this segment, make it this. The supraspinatus is active throughout the entire arc of abduction to compress the fulcrum.
Right.
The rotator cuff is physically deficient inferiorly. And the inferior glenohumeral ligament is your primary anterior restraint in abduction and external rotation. Avulse it, and you have a Bankart lesion.
Perfect summary. Now that the mechanical scaffolding is clear, we can trace the neurovascular structures that power it. The brachial plexus is intimidating because of its high variability and dense arborization, but we are going to rely on strict spatial relationships.
The basic structural progression from the spinal cord down to the peripheral nerves is roots, trunks, divisions, cords, and branches.
Always in that order.
The 5 roots, The ventral rami of C5 through T1 emerge between the scalene muscles in the neck. They combine into the upper, middle, and lower trunks. Behind the clavicle, they split into anterior and posterior divisions, separating the flexor and extensor compartments.
And then as they enter the axilla, they recombine into the three cords. The naming of those three cords is not arbitrary. They are named entirely based on their physical relationship to the second part of the axillary artery.
Which is sitting right behind the pectoralis minor muscle.
Exactly. The lateral cord sits lateral to the artery, the medial cord sits medial, and the posterior cord runs directly behind the artery.
Let's follow the lateral cord first. As we dissect down the arm, the lateral cord terminates by splitting into two major branches.
Yes, the lateral cord gives rise to the musculocutaneous nerve, which punches directly through the coracobrachialis muscle to innervate the biceps and brachialis. The other terminal branch is the lateral root of the median nerve, which crosses over the artery to join the medial root.
That's a crucial junction.
Very. Let me restate those two terminal branches. The lateral cord ends as the musculocutaneous nerve and the lateral root of the median nerve.
That brings us to the posterior cord, running behind the artery. This cord supplies the extensor compartments and the major internal rotators, and it is a massive exam focus. There is a 5-letter mnemonic that maps the branches perfectly. ULTRA, ULTRA.
Oh, I love ULTRA. So U for the upper subscapular nerve, L for the lower subscapular nerve, T for the thoracodorsal nerve heading down to the latissimus dorsi, R for the radial nerve, the massive extensor highway, and A for the axillary nerve wrapping around the surgical neck of the humerus.
Let's run that one more time.
Sure. Upper subscapular, lower subscapular, thoracodorsal, radial, axillary.
Now, the trap here, and it catches candidates in every single exam diet, revolves around those subscapular nerves. They innervate the subscapularis muscle.
Right.
When you visualize the subscapularis, it is plastered across the anterior face of the scapula. It's flush against the rib cage. It is the most anterior muscle of the rotator cuff.
And because the muscle is anterior, candidates rushing through a multiple-choice question assume the nerve supply must come from the anteriorly situated lateral or medial cords.
It just feels intuitive.
It does, but it's a trap. During embryonic development, as the limb bud rotates and the compartments form, the nerves that supply the internal rotators and extensors are all pulled from the posterior division. Therefore, despite the subscapularis sitting on the front of the shoulder blade, both the upper and lower subscapular nerves originate strictly from the posterior cord.
I want to make sure you do not miss that point on test day. Subscapularis is an anterior muscle, but it is innervated by the posterior cord. Both subscapular nerves come off the posterior cord.
Before we move distal to the cords, we must revisit the scenario you outlined at the very beginning of this deep dive. The trauma bay, the flaccid arm, the preganglionic root avulsion.
Oh, right.
You diagnosed that by testing the rhomboids and the serratus anterior.
Yeah, I knew those muscles were dead, which told me the lesion was medial to the trunks, right at the vertebral foramina. That is because the nerves supplying those muscles branch directly off the C5, C6, and C7 roots before the plexus even really begins.
Exactly. The dorsal scapular nerve branches directly off the C5 root to supply the rhomboids, and the long thoracic nerve takes contributions from the roots of C5, C6, and C7, dropping straight down the chest wall to supply the serratus anterior.
And if that nerve goes...
If the long thoracic nerve is dead, the serratus anterior is paralyzed, resulting in profound medial winging of the scapula. Because these branches tap straight into the roots, a deficit here means the roots themselves are damaged or avulsed from the spinal cord, which carries a pretty grim prognosis for surgical nerve grafting.
If you only keep one thing from the brachial plexus map, remember the terminals. The lateral cord gives you the musculocutaneous and median nerves. The posterior cord gives you the subscapular nerves. Don't fall for the anterior muscle trap, along with the axillary, radial, and thoracodorsal nerves. And the long thoracic nerve, supplying the suatus anterior, comes directly off the roots of C5, C6, and C7.
We have our nerve map. Now we trace those nerves into the danger spaces, the anatomical bottlenecks where these structures are tethered, compressed, or surgically vulnerable. Let's start with the suprascapular nerve.
Okay, so the suprascapular nerve carries massive amounts of sensory and pain fibers from the glenohumeral joint, along with a motor supply to the supraspinatus and intraspinatus. It branches off the upper trunk, primarily C5 and C6, and heads posteriorly toward the superior border of the scapula, aiming for a very specific bony cutout, the suprascapular notch.
Bridging across the top of that bony notch is a rigid band of connective tissue called the transverse scapular ligament. This creates a highly unyielding fibro-osseous tunnel. The suprascapular nerve and the suprascapular artery both arrive at this notch, but they take different paths to cross it.
And the examiners always want to know the spatial relationship of the nerve and the artery to that ligament.
The suprascapular nerve dives deep, passing under the transverse scapular ligament directly through the bony notch. Suprascapular artery, however, rides superficial, passing over the top of the ligament.
So there's a mnemonic for that, right?
Yes. The classic mnemonic, which honestly remains the best way to visualize it during a stressful exam, is army over, navy under. Artery over the ligament, nerve deep under the ligament. I will repeat this vital spatial relationship. Army over, navy under. The artery travels over the transverse scapular ligament, and the nerve travels deep under it.
Why does this actually matter clinically? I mean, if you have an elite overhead athlete, like a professional volleyball player, they are violently stretching that nerve against that rigid ligament thousands of times a week.
Yep. Constant microtrauma.
The nerve gets tethered and compressed right in that notch. Because the nerve goes under the ligament, it gets crushed against the bone, leading to a suprascapular neuropathy.
And because the entrapment happens at the suprascapular notch before the nerve gives off its branches, the patient will present with profound atrophy and weakness in both the supraspinatus and the infraspinatus muscles.
And then it keeps going.
Right. The nerve clears the notch, supplies supraspinatus, and then has to wrap around the base of the scapular spine through the sphenoglenoid notch to reach the infraspinatus.
Let's move down to the second major danger space, arguably the most important anatomical window for any shoulder surgeon performing open approaches or fracture fixations, the quadrangular space.
The quadrangular space is the exit route for the axillary nerve to leave the axilla and reach the posterior shoulder. It branches off the posterior cord, runs inferior to the subscapularis, and then dives posteriorly through this square window.
Because we don't have a textbook in front of us, we need to verbally build this four-sided box for the listeners. Picture dissecting the posterior shoulder. You split the deltoid, and you are looking at the rotator cuff muscles. You need to identify the four borders of the quadrangular space to find the axillary nerve safely.
Let's build the box.
Let's do it.
The superior border, the roof of the space, is formed by the teres minor muscle. The inferior border, the floor of the space, is formed by the teres major muscle.
And the sides.
The medial border, the inner wall, is formed by the long head of the triceps as it travels up to attach to the infraglenoid tubercle. And the lateral border, the outer wall, is formed by the surgical neck of the humerus itself.
That's a lot to visualize.
Let me construct that window one more time. Superior is teres minor. Inferior is teres major. Medial is the long head of the triceps. Lateral is the surgical neck of the humerus.
And the axillary nerve passes straight through the center of that space, accompanied by the posterior circumflex humeral artery. It is sitting flush against the surgical neck of the bone, exactly where a proximal humerus fracture occurs. If the surgical neck shatters and displaces, the jagged cortical bone shreds the axillary nerve.
Exactly.
Yeah.
It is also the primary structure at risk during a Latarjet procedure. When you perform an open anterior stabilization, you take the coracoid process and transfer it to the front of the glenoid. To get to the glenoid, you have to split the subscapularis muscle horizontally.
Right.
The axillary nerve is running transversely just millimeters inferior to the lower border of the subscapularis. If your retractor slips, or if you dissect too far inferiorly during that muscle split, you will transect the axillary nerve.
And if the axillary nerve is crushed, the deltoid and the teres minor are paralyzed. The patient loses their primary shoulder abductor and their ability to actively externally rotate in abduction. The clinical presentation is a shoulder that basically cannot be lifted, and the weakness is most exaggerated when you test abduction while the arm is internally rotated.
Why internally rotated?
Because you have completely neutralized any compensatory mechanical advantage from the biceps or other muscles.
Spot on. In cases where the axillary nerve is completely severed and cannot be repaired directly, we have to look at reconstructive salvage options. The exam occasionally tests the specific nerve transfer used here.
The Leach-Wingong's procedure.
Yes, the Leach-Wingong's transfer. To restore deltoid function, the surgeon goes to the posterior arm and identifies the radial nerve in the spiral groove. They dissect out a redundant motor branch of the radial nerve that supplies the long or medial head of the triceps.
Because the triceps has multiple motor branches, you can sacrifice one without losing elbow extension.
Precisely. The surgeon cuts that triceps branch distally, swings the live proximal stump upward into the quadrangular space, and coaps it directly to the distal stump of the dead axillary nerve. You are essentially hot wiring the deltoid using power from the triceps.
That is reconstructive anatomy at its finest. Let's lock down the danger spaces. If you only keep one concept here, burn these relationships into your memory. At the suprascapular notch, the relationship is strictly army over, navy under artery superficial, nerve deep. And the quadrangular space, housing the axillary nerve, is bordered by the teres minor superiorly, teres major inferiorly, triceps long head medially, and the surgical neck of the humerus laterally.
Before we start crossing the elbow and heading into the forearm, let's take a moment to consolidate the proximal map we just built. It's time for our first pit stop.
Okay, let's run the mental checklist. We started with the shoulder stabilizers. The supraspinatus is active throughout the entire arc of abduction to compress the fulcrum. The rotator cuff capsule is physically deficient inferiorly. Your primary anterior static restraint in the throwing position abductions and external rotation is the inferior glenohumeral ligament, and tearing it off the glenoid creates a Bankart lesion.
Keep going.
Moving to the plexus, the lateral cord terminates as the musculocutaneous and median nerves. The posterior cord gives you the subscapular nerves, plus the radial, axillary, and thoracodorsal nerves. And in the danger spaces, remember army over, navy under at the suprascapular notch, and the teres minor, teres major, triceps, and humerus, forming the borders of the quadrangular space for the axillary nerve.
The proximal map is set, but nerves and muscles die without adequate plumbing. Let's shift our focus to the blood supply, starting with the humeral head.
The vascular anatomy of the proximal humerus dictates how we classify and treat fractures, right?
Absolutely. If the blood supply is destroyed, the humeral head undergoes vascular necrosis, it collapses, and the patient ends up needing a joint replacement instead of fracture fixation.
Historically, and for the purposes of the FRCS exam, the dominant blood supply to the humeral head comes from one specific vessel.
Yes, the required exam answer is the anterior humeral circumflex artery. This artery branches off the third part of the axillary artery, wraps around the front of the surgical neck, and then sends a critical vertical branch straight up the arm.
The ascending branch, also known as the arcuate branch. It travels directly up the bicipital groove, running laterally alongside the long head of the biceps tendon. It runs up that groove, enters the bone at the top of the intertubercular sulcus, and perfuses the vast majority of the humeral head.
That is the textbook anatomy. The anterior humeral circumflex, via its ascending branch, is the main blood supply.
Now, I need to inject a dose of clinical reality here, because surgical literature over the last decade has heavily challenged this. If you read the landmark anatomical injection studies by Hetrick and others, they mapped the vascularity of cadaveric shoulders.
And what did they find?
They found that the posterior circumflex humeral artery actually provides the vast majority of the blood flow to the humeral head, specifically supplying the entire posterior aspect, the greater tuberosity, and the postero-inferior quadrant.
Right. The Hetrick paper revolutionized how we think about the blood supply in the operating room. We now know the posterior circumflex is incredibly robust, often providing over 60% of the perfusion. However, this is where you have to separate your clinical reading from your exam strategy.
The syllabus is the syllabus.
Exactly. Standardized exams have a massive lag time. If the question asks you to identify the primary blood supply to the humeral head, you do not debate the recent literature in your head. You mark the anterior humeral circumflex artery. You take the point, and you pass the exam.
It's all about playing the game.
I will repeat the strict exam answer twice to ensure there is no confusion on test day. The main blood supply to the humeral head is the anterior humeral circumflex artery. The exam answer is the anterior humeral circumflex artery.
Understood. Play the game the examiner set. Let's trace down the posterior arm to the elbow. The triceps muscle is a massive three-headed extensor, but the exam zeroes in on a very specific biomechanical detail about how it inserts onto the olecranon, the proximal tip of the ulna.
When you perform an open reduction and internal fixation of an olecranon fracture, you often use a tension band wiring technique.
Right, where you drive two parallel Kirschner wires down the shaft of the ulna, and then you loop a figure of 8 wire through a drill hole and wrap it around the proximal tip of the olecranon to compress the fracture.
To do this safely, you have to understand the anatomy of the triceps insertion.
Because the triceps doesn't insert as a single uniform block of tendon, does it? It has a primary tendinous insertion and a secondary thinner fascial expansion.
Yes. The central, thick, heavy tendon, the triceps, proper inserts purely onto the posterior 40% of the olecranon tip.
Only 40%.
Just 40. The remaining 60% of the olecranon footprint, moving anteriorly toward the joint surface, is covered by the articular capsule, a bursa, and a thin superficial fascial sheet called the triceps expansion, which blends laterally into the fascia of the anconeus muscle.
So when you are passing your tension band wire, you have to stay deep to that main triceps tendon to get a solid mechanical hold on the bone, but you absolutely cannot violate the joint capsule sitting just anterior to it.
And that requires knowing the exact real estate the main tendon occupies. The main triceps tendon inserts onto strictly the posterior 40% of the olecranon tip. I will give you that number twice. The triceps proper tendon occupies exactly the posterior 40% of the olecranon.
If you only retain one fact from this section on plumbing and extensions, lock this in. The strict exam answer for the main blood supply to the humeral head is the anterior humeral circumflex artery, and the main triceps tendon inserts onto exactly the posterior 40% of the olecranon tip.
Moving distally, we enter the forearm. Surgical exposures in the forearm are notorious for their proximity to major motor nerves. If you have a diaphyseal fracture of the radius, you need to expose the bone to apply a compression plate.
And the classic posterior approach to the radius shaft is the Thompson approach.
Yes. To get down to the bone safely, you can't just cut through muscle bellies. You have to find an internervous plane.
That's a natural seam between two muscles that are supplied by different nerves, or at least different branches, so you can pull them apart without denervating either one. The examiners will ask for the specific muscles that form the proximal interval for the Thompson approach.
The proximal interval for the Thompson approach is found by separating the mobile wad laterally from the extensor mass medially. Specifically, the seam is between the extensor carpi radialis brevis, the ECRB, and the extensor digitorum communis, the EDC.
Let's visualize that. You incise the skin on the back of the forearm, you identify the fascial plane, and you split the ECRB and the EDC.
Let me reiterate that interval for your notes. The proximal interval for the Thompson approach is between the ECRB and the EDC.
You retract the ECRB laterally, you pull the EDC medially, and you look deep into the wound. You are staring right at the supinator muscle, which is wrapped around the proximal third of the radius. And buried inside that supinator muscle is a landmine.
The posterior interosseous nerve, the PN, the deep motor branch of the radial nerve. It enters the supinator muscle through a fibrous arch called the arcade of Froese, and it spirals around the neck and proximal shaft of the radius.
And if you just slap a retractor down onto the radius bone and pull forcefully,
you will crush or transect the PN.
A transected pin is a catastrophic complication. The patient wakes up with a massive finger drop and thumb drop. They can extend their wrist because the ECRL is spared, but they cannot extend their digits at the metacarpophalangeal joints. So how does the surgeon protect this nerve while exposing the bone? You use a biomechanical trick.
You manipulate the position of the forearm. When the arm is pronated, the radial tuberosity rotates medially, and the supinator muscle, carrying the penine, sits draped right over the posterior aspect of the radius, directly in your surgical field.
Right in the way.
Exactly. To get the nerve out of the way, the surgeon must firmly supinate the patient's forearm.
Turn the palm face up.
By fully supinating the forearm, the radius rotates laterally. The supinator muscle contracts and unwinds, and as it does, it physically drags the posterior interosseous nerve anteriorly and medially, sweeping it safely away from the posterior surgical field. Supination pulls the nerve out of the danger zone.
It's an elegant use of dynamic anatomy. The interval is between ECRB and EDC, and you supinate to sweep the pin to safety. Let's continue distally, crossing the wrist and entering the complex terrain of the flexor tendon zones in the hand.
The flexor tendons on the palmar surface of the hand are divided into 5 surgical zones based on the anatomy of the tendon sheaths and pulleys. The numbering starts at the distal tip of the fingers as Zone 1 and moves proximally to the forearm as Zone 5.
Historically, Zone 2 was referred to by hand surgeons as no man's land. Sterling Bunnell coined that term because if a patient lacerated their flexor tendons in this zone, attempting a primary surgical repair almost universally ended in a stiff, non-functioning finger.
The anatomical complexity in Zone 2 is staggering. You have 2 tendons, the superficialis and the profundus, gliding in very tight proximity inside a single, unyielding fibroosseous tunnel surrounded by a delicate synovial sheath.
And if you suture a cut tendon here,
the bulky knot of the repair gets jammed in the tight A2 pulley, creating dense scar tissue and adhesions. The tendons literally glue themselves to the bone.
But the defining anatomical feature of Zone 2, the specific structure the examiners will ask you to locate, is Camper's chiasma. Let's describe the mechanical interaction of these 2 tendons, because it looks like a complex pulley system or the rigging of a sailboat.
It is an incredible piece of biomechanical engineering. You have the flexor digitorum superficialis, the FDS. This is the superficial tendon sitting closer to the skin. Deep to it, lying flush against the bone, is the flexor digitorum profundus, the FDP.
And the deep tendon, the FDP, has a long journey. It needs to travel all the way to the very distal tip of the finger to insert on the distal phalanx and flex the fingertip.
Right, but the superficial tendon, the FDS, is physically blocking its path.
Exactly. So to let the deep tendon pass, the superficial FDS tendon physically splits in half. It divides into two lateral slips. These two slips move to the sides, wrap circumferentially entirely around the deep FDP tendon, rotate 180 degrees, and reunite deep behind it to insert onto the base of the middle phalanx.
The FDS basically forms a structural buttonhole, and the FDP threads the needle right through it.
That highly specific anatomical cropping, where the superficial tendon splits, wraps around the deep tendon, and forms a tunnel for the deep tendon to pass through, is Camper's chiasma. And the exam fact you must know cold is the location.
Yes, Camper's chiasma is located exclusively within flexor zone 2. Let me state that twice. Camper's chiasma exists strictly in zone 2. Camper's chiasma equals zone 2.
Just to give a brief spatial orientation for the rest of the map. Zone 1 is distal to the superficialis insertion, so it only contains the profundus tendon. Zone 2 is from the middle of the middle phalanx down to the distal palmar crease containing the chiasma.
And zone 3 is the palm, where the lumbrical muscles originate.
Right. Zone 4 is the tight carpal tunnel, and zone 5 is the forearm proximal to the wrist.
But zone 2, containing Camper's chiasma, is the high-yield target.
Let's lock in our distal section. If you only remember one thing about the forearm and hand, the Thompson approach goes between the ECRB and EDC, and you must supinate the arm to drag the posterior interosseous nerve to safety. In the hand, the intricate tendon crossing of Camper's chiasma lives entirely within flexor zone 2.
We have mapped the entire limb from the shoulder to the fingertips. Before we tackle the final anatomical bottleneck at the root of the neck, let's do our second mid-episode review.
Let's run the distal checklist. The main exam answer for the humeral head blood supply is the anterior humeral circumflex artery, specifically the ascending branch in the bicipital groove. The main triceps tendon inserts on exactly the posterior 40% of the olecranon tip, which is crucial for tension band wiring.
Keep it going.
The Thompson approach proximal interval is between the ECRB and EDC, and you supinate to protect the pine. And Camper's chiasma, the tendon crossover, is the defining feature of flexor zone 2.
The map is almost complete. But to truly understand the upper limb, we have to zoom all the way back up to the origin. We have to look at the ultimate bottleneck, where the massive vascular trunks and the brachial plexus emerge from the thorax and the spine to enter the axilla.
We are talking about the root of the neck, and specifically, the first rib.
The anatomy of the first rib is the foundation for understanding thoracic outlet syndrome and for safely placing central venous lines. Unlike your lower ribs, which sit vertically like the bars of a cage to protect your lungs, the first rib is short, incredibly broad, flat, and lies horizontally at the base of the neck.
It forms the bony floor of the doorway into the arm.
Because every major vessel and nerve must pass over this flat, bony floor, they carve distinct grooves into its superior surface. And the organizing landmark on that surface is a small, spiky, bony prominence on the inner margin of the rib called the scalene tubercle.
The scalene tubercle is the insertion point for a thick, powerful muscle called the scalenus anterior, which drops down from the transverse processes of the cervical spine.
Think of the scalenus anterior muscle as a massive physical barrier, a traffic cop standing directly on the first rib, organizing the neurovascular highway. The tubercle it attaches to divides the upper surface of the first rib into two distinct compartments.
The examiners will ask for the exact structures that run in front of and behind this tubercle.
Anterior to the scalene tubercle in front of the muscle insertion, the first rib has a shallow groove that transmits the massive subclavian vein. Posterior to the scalene tubercle, behind the muscle insertion, there is a second, deeper groove that transmits the subclavian artery, lying immediately adjacent to the lower trunk of the brachial plexus.
So the vein is in front, the artery and the plexus are in the back. The scalenus anterior physically separates them.
This is a life-or-death spatial relationship.
Yeah.
If you are a surgical resident placing a subclavian central venous catheter, you are sliding a large needle under the clavicle, aiming for the sternal notch, trying to puncture the subclavian vein.
And if you aim wrong,
if you direct your needle too far posteriorly, you will puncture the subclavian artery, causing a massive, non-compressible hematoma. If you go too deep, you hit the pleura and drop the lung, causing a pneumothorax.
The scalenus anterior acts as the physical wall protecting the artery from your needle. The vein sits freely in front of it. I will repeat this vital anatomy. At the first rib, the subclavian vein passes anteriorly in front of the scalene tubercle. The subclavian artery passes posteriorly behind the scalene tubercle, sandwiched between the scalenus anterior and the scalenus medius.
There is one final nerve to place on this map. It doesn't enter the arm, but it is intimately related to the scalenus anterior muscle.
The phrenic nerve. It originates from C3, C4, and C5. C3, 4, 5 keep the diaphragm alive.
As the phrenic nerve descends through the neck toward the chest cavity, it runs vertically, plastered straight down the anterior superficial face of the scalenus anterior muscle, crossing from lateral to medial. If you are doing a neck dissection or exploring the brachial plexus roots, you will see the phrenic nerve pinned right against the front of that muscle.
Let's wrap up this final anatomical section. If you only keep one image in your mind regarding the root of the neck, visualize this. At the first rib, the scalenus anterior muscle acts as the great divider. It forces the subclavian vein to run in front of it and forces the subclavian artery and plexus trunks to run behind it, while the phrenic nerve travels vertically right down its anterior face.
Master that bottleneck, and you understand the gateway to the upper limb. You have successfully mapped the highways and the intersections.
Which means it is time to stress test your recall. We're entering the lightning round. I am going to fire off the core concepts we just spent the last hour dissecting, and our expert is going to give you the immediate, precise exam answer. Try to anticipate the answer and shout it out before the expert speaks. Let's run it.
Ready.
What is the action of the supraspinatus muscle, and where is the rotator cuff anatomically deficient?
Supraspinatus is active throughout the entire arc of abduction. The rotator cuff is deficient inferiorly.
What is the primary static restraint to anterior translation in the throwing position, abduction, and external rotation?
The inferior glenohumeral ligament. A traumatic avulsion is a Bankart lesion.
Does a normal subacromial bursa communicate with the glenohumeral joint?
No. If dye leaks into the bursa, it indicates a full-thickness rotator cuff tear.
Name the two terminal branches of the lateral cord of the brachial plexus.
The musculocutaneous nerve and the lateral root of the median nerve.
Which specific cord gives rise to the upper and lower subscapular nerves?
The posterior cord. Remember, it is an anterior muscle with a posterior supply.
At the suprascapular notch, what is the spatial relationship to the transverse scapular ligament?
Army over, navy under. The artery goes superficial over the ligament. The nerve goes deep under the ligament.
Name the four borders of the quadrangular space and its vital contents.
Borders: teres minor superiorly, teres major inferiorly, triceps long head medially, humerus laterally. Contents: the axillary nerve and the posterior circumflex humeral artery.
What is the strict exam answer for the main blood supply to the humeral head?
The anterior humeral circumflex artery via its ascending branch.
What is the proximal interval for the Thompson approach to the radius, and how do you protect the nerve?
The interval is between the ECRB and the EDC. You must protect the posterior interosseous nerve by supinating the forearm.
In the flexor tendon anatomy of the hand, what zone houses Camper's chiasma?
O2.
Finally, at the first rib, what separates the subclavian vein from the subclavian artery?
The scalenus anterior muscle attaching at the scalene tubercle. The vein runs in front. The artery runs behind.
Take a breath. Congratulations on surviving the upper limb nerve map. We have covered a massive expanse of dense, highly testable surgical anatomy. If you can visualize the borders of the quadrangular space, and if you know exactly how supination protects the PNI, you have mastered the classic traps the examiners use to separate the safe surgeons from the dangerous ones.
It requires a fundamental shift in perspective, and that shift is the perfect transition to what we will tackle next time. In our next deep dive, we are leaving the world of human tissue entirely. We are entering the realm of orthopedic engineering and biomaterials.
We're going to break down the metal and the plastic, stress strain curves, the definitions of stiffness and fatigue, viscoelasticity, and the structural mechanics of why plates bend and why screws inevitably fail.
It is a mathematically dense topic, but once you understand the core mechanical principles, you will realize that one single graph essentially answers half of your biomaterials questions.
Before you turn off your car or finish your chores, I want to leave you with a final provocative thought regarding what we did today. Think about how learning anatomy using this specific framework, mapping it not by memorizing passive origins and insertions, but by aggressively memorizing the vulnerabilities and the danger spaces. Think about how that completely shifts a surgeon's mindset in the operating room.
It changes everything.
You are no longer just a passive observer of the body's structure, By memorizing exactly where the wiring is most exposed, you become an active protector of it. Your entire approach to surgical dissection becomes defensive.
A defensive dissection is a safe dissection, and a safe surgeon is exactly what the examiners are looking to credential. Keep building that map in your mind.
You are one massive step closer to conquering the FRCS. Keep studying, and we will catch you on the next deep dive.